The OASIS intervention is a comprehensive organizational level intervention designed to improve antibiotic prescribing in participating skilled nursing facilities. This video is one part of a series designed to provide nursing home staff with education of the OASIS intervention. In this video, we will go over how nursing home staff in facilities can influence provider decisions to initiate antibiotics, and also how antibiotic use and safety can be improved through nursing home interventions. The skilled nursing facility environment is unique. In providing a context for the intervention, we hope that all nursing home staff will feel empowered to positively affect the safety and health outcomes of residents in your facility. So when we look at antibiotic prescribing in skilled nursing facilities, it's easy to feel like this is a prescriber problem. And this cartoon is intended to kind of highlight the situation where it seems like the director of nursing and the registered nurse are doing all of the hard work while you have the emergency room physician and the cross-covering physician often standing by idly and being part of the problem when part of the solution. And certainly I think the situation does occur quite frequently in nursing homes, and it's easy for nursing home staff to feel powerless, like they have no control over this situation. However, if you look at the prescriber perspective and what are the factors that influence their decision, I'm hoping that we can convince you that you actually have a lot more control over this decision than you think you do currently. So when you look at all the factors that influence a prescriber's decision to initiate antibiotics, it's important to note that there are several factors influencing this decision. Certainly, characteristics of the prescriber themselves are a major factor. We know that residents as well as families of residents can exert some influence on this decision. But nursing home staff and the nursing home environment also have an important role here. And that's what's highlighted in the bottom left of this figure. And you may ask yourself, well, how is that? And what influence do we really have? Well, I think first it's important to understand that this effect does exist. This slide is intended to show you the contextual influence that nursing homes have on prescribing decisions in this environment. The top figure on the left is showing variation in antibiotic use across 6 different nursing homes in Wisconsin. And what you can see here is that there's fourfold variation across these 6 facilities. And it's important to note that the types of residents in these facilities are very similar. So that already is telling you that there's something beyond resident characteristics that's influencing decisions to start antibiotics. There's also a study that was published in New York, which is shown in the bottom left, showing degree of variation within facilities, again, looking at variation across providers practicing in the same nursing home. And while there is some variation there, what we're seeing is that variation is much less than the variation that we see between nursing homes. So what does this tell us? It says that prescribers develop prescribing patterns that are similar to other providers in the same nursing home. And this pattern of practicing like other prescribers in the facility exists even if the prescribers work in different settings outside of the nursing home. So there's something about the nursing home that is causing some commonality between prescribing patterns. And this is not something that we see just with antibiotics. We've seen similar effects when we look at medications like antipsychotics and anticoagulants. So this is a common feature that's telling us a lot of information that nursing homes are influencing the decision to start antibiotics. It doesn't tell us how they are influencing the decision to start antibiotics, only that effect exists. So the thing to remember as a nursing home staff is that there are some things that you just can't control directly. Certainly you can't control desires by the residents and the families for antibiotics. And certainly you can't control characteristics of the prescriber. But there are some things that nursing home staff can influence indirectly. So let's look a little bit at prescriber factors that influence decision making. We know that prescribers come with a wide array of knowledge and skills as well as experience. We also know that many of the prescribers have very different workloads both within and outside of the nursing home. And we also know that providers have varying degrees of familiarity and different relationships with the resident and the family. All of these things will influence their prescribing threshold or willingness to start antibiotics or unwillingness to start antibiotics. But I would say the two biggest factors that contribute to that antibiotic prescribing threshold are the prescriber's intrinsic level of risk aversion, how much risk are they willing to tolerate, as well as how much tolerance they have for diagnostic uncertainty. And these are the two characteristics where I think nursing home staff can have an indirect influence on that prescribing threshold or decision to start antibiotics. So what do I mean by that? Well, I think that nursing home staff can influence both provider risk aversion and tolerance for uncertainty through three main interactions. The first is the thoroughness of the assessment of the resident change in condition. How well does the nurse do their job in assessing what are the facets of the physiology, localizing symptoms and complaints, exam findings that occur with that change in condition. And it doesn't matter how good of a job the nurse does in doing that assessment if they don't communicate those findings effectively to the provider. I'll show you in several slides here interview quotes from providers that show that the thoroughness of that assessment as well as the thoroughness of that communication has a big influence on their perception of the nurse assessment and as a result their willingness to withhold antibiotics or frankly start antibiotics. The other thing that nurses need to understand is that when you are calling a provider over the phone, whether you think it or not, they think you want something from them. And whether you say it explicitly or whether you are more vague about what you want, the prescriber is going to try to read into your language to give you what you want. Not all the time, but often they will. And so you can have a big influence on this process by making your wants and desires about how to manage that patient more explicit. And then finally, circling back on the resident to look at whether there's opportunities to modify the antibiotic regimen, which is something that we don't commonly do, is another opportunity that nursing home staff can trigger to improve the safety of antibiotic use. And specifically here is looking at updated information. Has the resident improved? Do we have new culture data? Do we have new imaging studies? All of which may allow the provider to make some decisions and changes in the antibiotic therapy that makes it safer. Certainly this empiric prescribing is made under a lot of diagnostic uncertainty, and once more information is available, it might be possible to narrow antibiotic therapy or shorten antibiotic therapy to make that prescribing event safer. So let me show you a little bit of our interview data that we've had with prescribers. This is an interview quote from a provider, basically him telling us what he's looking for when he's on the phone with a nursing staff. And he quotes, "I usually press for details. For example, what is the temperature? How long has she had the cough? Is this a sudden change or is this a gradual change? Has it ever happened before?" And some nurses will call and they'll have all of that available. Others do not, and it's highly variable. So again, you can see that the provider is looking for specific types of information, and the prepared nurse who either provides this information up front or has it readily available is going to make that communication event much more effective, is going to make the provider a lot more comfortable with that assessment, and as a result is likely going to make them more willing to withhold antibiotics and rely on the nurse to contact them if anything changes. And this is reflected in a second interview that we had with another provider. And we asked them, are there characteristics of either the facility that the resident is in or the nursing staff caring for him that also influence your comfort level with holding off on starting antibiotics? And this provider said, and so I probably would, trust information from them maybe a little bit at a higher rate. So I know them, know what they're capable of. So you probably wouldn't, feel more comfortable with some of the judgments that they passed on one way or the other. And then we went on to ask further, and is it fair to say that that does have some influence on your decision to? And before we could even get the antibiotic prescribing out, the prescriber said, oh, it is. So again, having that information available at the ready is going to make this conversation go a lot easier, and you're going to do a lot to allay some of the diagnostic uncertainty and the risk aversion that provider is going to have. And when we look at studies that have tried to improve the effectiveness and quality of communication and specifically its effects on antibiotics, we found that standardizing the quality of assessment and communication does impact antibiotic prescribing. This is a study that was performed in 12 Texas nursing homes. And this intervention focused on using a standardized assessment communication tool for suspected urinary tract infection. And what they found were that nursing homes that implemented the communication form and process with high levels of fidelity were able to reduce their antibiotic use by 24% compared to nursing homes that either never implemented the form or implemented it with low fidelity, again showing that simply improving communication can have a major impact on antibiotic decisions in nursing homes. Now the other thing to remember, as I mentioned, is that prescribers believe that the nurse has an agenda when she's calling the phone, when she's calling on the phone or he's calling on the phone. They're trying to understand, what does this person on the other end of the phone want from me? And you're going to make this process a lot better if you're much more explicit about what you want from the prescriber. So this is just an example showing the same scenario, but with two different types of scripted language. And I'd like you to just ask yourself, which of these scenarios is more likely to result in an antibiotic being prescribed? So in this scenario, Mrs. Sleepy is an elderly long-term stay resident with dementia who appears more lethargic than usual and is refusing to come out of her room for meals. Her vital signs are stable, and she has no localizing complaints. So in the first example, the nurse is calling Dr. Jones and says, "Dr. Jones, Mrs. Sleepy is less interactive and not coming out of her room. Do you want me to send a urine culture?" Now, in a very different type of interaction, the same nurse calls the same doctor about the same patient and says, "Dr. Jones, Mrs. Sleepy is less interactive and not coming out of her room. She has no fevers, her other vital signs are stable, and she has no concerning exam findings today. Would you be okay with me encouraging fluids and monitoring her closely over the next 48 hours? I think you would agree that using this scenario B is much less likely to result in an antibiotic being prescribed than taking the approach in example A. And the other thing to remember is that testing the urine is not harmless. So a lot of our focus in nursing homes is about the decision to not start an antibiotic. But I would argue that the decision to send a urine culture is what starts this cascade in the first place. So another thing that we need to be focusing on when we contact the provider is that decision to order a urine culture. And so remember that this is not a harmless decision. In the nursing home resident population, urinary tract infections are not a laboratory diagnosis. They are a clinical diagnosis. We know that abnormal urinalyses and positive urine cultures are very frequent in this setting. 50% of females who reside in nursing homes have an abnormal urinalysis or urine culture, and 25% of males have an abnormal urinalysis and urine culture. A urinalysis can be used to rule out the presence of a UTI if it's normal, but if the urinalysis and the urine culture is abnormal, that does not, by extension, rule in a urinary tract infection. In general, urinary tract infections manifest themselves with some type of clinical exam finding, and a positive test by itself means nothing from this perspective of a diagnosis of UTI. Now this is important because we have a lot of discontinuous information exchange going on in nursing homes. The provider who orders the urinalysis and urine culture may not be the same provider who gets the test results. In fact, 60 to 90% of antibiotics prescribed for urinary tract infection are started after the culture results are back. And I'd like to share with you a few scenarios to show how this could be problematic. So in this scenario, Mrs. Updown is an 85-year-old female with dementia who develops minor confusion during the day shift. The nurse calls the provider, Dr. Wynot, to report this change in condition and finishes her report with, "Do you want me to send a urine?" Dr. Wynot knows the resident well and is doubtful the resident has a urinary tract infection, but agrees to order a urinalysis and urine culture. Late the next afternoon, the nurse receives a report that Mrs. Updown's urine culture is positive for greater than 100,000 E. coli. The nurse attempts to contact Dr. Wynot, but ends up getting the on-call provider, Dr. No Time. During the phone call, the nurse informs Dr. No Time of the positive culture results, but does not provide an update on Mrs. Updown's symptoms. In fact, she was back to her baseline at this point. And Dr. No Time doesn't ask for further information. Hearing the culture results, Dr. No Time prescribes Mrs. Updown 7 days of ciprofloxacin. And unfortunately, in this situation, 4 weeks later, Mrs. Updown is admitted to the hospital with C. difficile diarrhea. Now contrast this with two different scenarios, one being perhaps a slight improvement, and hopefully the other one, which is what I hope we are able to move to more consistently. So in scenario 2, we have the same scenario with Ms. Updown's mild change in condition, and the same urinalysis was sent off after the first conversation with Dr. Wynot. But in this case, when the results come back, the nurse is able to get in touch with Dr. Wynot and relays the urine culture results. Dr. Wynot, remembering that Mrs. Updown has a history of fluctuating mental status, asks the nurse how Mrs. Updown is doing. The nurse reports that Mrs. Updown's confusion has resolved and that she appears to be back at her baseline. Dr. Wynot suspects that Mrs. Updown has asymptomatic bacteriuria and does not order an antibiotic. 4 weeks later, Ms. Updown celebrates her birthday with her family. Now, in the best scenario, Mrs. Updown develops confusion, but now with the initial interaction between the nurse and Dr. Wynot, the nurse says, Mrs. Updown has no specific urinary symptoms and is otherwise stable. Would you be okay with us watching her closely, encouraging oral fluid intake? Dr. Wynot agrees with this active monitoring plan, and a urine culture is never sent. The nurse, with all of her free time now, is able to help Mrs. Updown plan her birthday celebration that will occur in 4 weeks. And we now have some empirical evidence to back up that nursing homes that put a focus on reducing unnecessary urinary testing can actually have a significant impact on urinary tract infection rates. This is a different study performed in 12 nursing homes in Massachusetts, which focused purely on the decision to send off a urine culture. And they used a standardized decision support tool that nurses were able to work through to determine whether a urine culture should be sent or not. And if the resident didn't meet criteria for starting an antibiotic or sending off a urine culture during their communication with the provider, they would explicitly state that in this situation, the resident probably doesn't need a urine culture to be sent. It's important to note that this intervention only focused on the urine culture decision and had no influence or no direct influence on the decision to start an antibiotic. And all decision-making was left up to the providers. So this was purely a nursing home staff intervention, and there were no interventions targeted at the providers. And what they saw over time as they rolled out this intervention focused on reducing urine testing, their urine culture rate dropped by over 50%, and as a result, their UTI rate dropped by nearly 60%. And while the results were not statistically significant, rates of C. difficile in this facility dropped by 15%. As I mentioned, the third mechanism by which nursing staff can influence antibiotic safety is through prompting a review of antibiotic use after an antibiotic has been started and talking with the provider to see if there are opportunities for stopping antibiotics, narrowing antibiotics, or shortening antibiotics. And we believe that there's a lot of opportunity for improving the safety of antibiotics even if we have no impact on the decision to start antibiotics. This is data from several Wisconsin nursing homes that looked at 162 prescribing events for urinary tract infections. And what we found was that 33% of the antibiotics that were started for a UTI indication were continued despite urine culture results subsequently coming back as negative. So in another third of antibiotic courses started for UTI, we found that the antibiotics were never changed despite the urine culture showing that the bacteria recovered was resistant to the empirically initiated antibiotic. And in numerous other situations, we found that the antibiotic that was started could be modified to a less risky antibiotic. So in many situations, the residents were started on ciprofloxacin, which is a broad-spectrum antibiotic that carries a very high risk of C. difficile colitis, when the resident could be changed to a safer narrow-spectrum antibiotic like Bactrim or nitrofurantoin. So what we've covered in this video is how skilled nursing facilities can affect antibiotic use. For additional information on why antibiotic use in skilled nursing facilities matter, the components of the OASIS Collaborative, including examples of how the components are intended for use, please see the other videos in this series.